I'm a breast cancer survivor. Oh my God, this is the first time I say it.
Good afternoon. We are now continuing our educational initiative on the care and management of the patient with a HER2 positive breast cancer. In our previous discussions, we have covered in some detail the relatively protracted treatment that is incurred by patients who ultimately decide to undergo preoperative neoadjuvant chemotherapy for many, many months before they present to undergo a surgical procedure. So along the way, we really do need assistance to continue to encourage the patient on the choice they have made and assure them that that is the right choice. We as physicians and healthcare workers cannot be present 24 hours a day with a patient when questions arise. And for that reason, we aim to give them some idea of where they can seek additional information. I am biased in that we have a navigator program here, which is unlike any other program in the country. We have women who are not necessarily healthcare workers, some of them are. Many are breast cancer survivors who have undergone many of the treatments that we talk about, but who have elected to undergo a rigorous course of nearly 9 to 12 weeks, during which they are familiar with the basic approaches to the diagnosis and management of breast cancer. And these individuals accompany the patients just like a relative or a friend who has undergone breast cancer treatment during the patient's newly diagnosed difficulties. So I'd like to start with one of my own colleagues and navigators to see to what extent she finds the work she does not only significant, but also does in fact affect the patients who make the decision to undergo preoperative chemotherapy for a HER2 positive breast cancer. Dan?
Thank you, Dr. Silva. Being a navigator is very important, and it's a role that we take very seriously to help the patient understand what is going to be happening and to explain to them. And a lot of times they may not understand what their doctor has told them, or the doctor may have told them something and they don't remember having it being discussed at the appointment. Mm-hmm. And so we are that extra set of eyes and ears, having gone through our training, that they can call us day, night, weekend, and ask that question, if they have a question. And if we don't know it, we have our other navigators we can turn to, or we can email, Dr. Silva, and, he can help us out also. So that way they know they always have somewhere to turn, and if they can't get a hold of their doctor or the nurse, that way they're not left, through a whole entire weekend wondering, what if and what's going to happen next.
I'm a pharmacist, and I was overwhelmed by all the medications, the possibilities, everything. It's so important to have someone with you. You don't absorb, but maybe 20% if that. So I always had someone go with me, and then I would ask a question at home, and my husband would be like, well, yeah, they said this. Don't you remember? And I was like, I have no knowledge of that.
We aim to get the navigator involved at the very beginning, even before a diagnosis of breast cancer is made, because most patients have an abnormal mammogram or abnormal physical finding. And I think among the most important features of the, if you want to call it longitudinal care of the HER2 patient, is that they do not undergo an excisional biopsy. We know that in doing so, the patient has eliminated the patient's opportunity to participate in this approach, which we recommend, namely the use of preoperative neoadjuvant chemotherapy. After all, if you remove the cancer from the breast to make a diagnosis, then you have nothing to measure the response to chemotherapy for. Forget that and look at the NCCN guidelines that say that for every 10 biopsies we do in the US, only one is cancer. As a result of that, we then know that our navigators are very, very keen when a patient says they're scheduled to undergo such a procedure, and can correct that course by saying to them, perhaps we need to go back and ask the physician if a core biopsy would not be sufficient for the same purpose. In addition to that, the navigators do report to our coordinator, and we have a robust data bank of these approaches, And the idea of the navigators ultimately, as I have made it clear, is not only to accompany the patient through their journey, but to ascertain that at the end of the journey, they have received what we would recognize as a best practice according to NCCN standards. And Laura, who was our coordinator, keeps that data bank and is able to, at the end of that individual's time frame, show to her that not only did she do well, but that the treatment that she received has met what is now considered to be best practice standards, not by Dr. Silva, not by Dr. Smith, not by a medical oncologist, but by the NCCN. Laura?
So our program was actually generated from the same person who created the database for a navigator program at UC Davis. So it was really nice because it was something that was already put together in a really nice way for us to track our patients. We can put their diagnosis and their treatment information in there. The navigator has access to the patient portal as well, so that they can log all of their encounters in there. Some navigators prefer that I actually go in there and enter the information, which is fine. I know Diana's really great about entering that information right when it happens, and we're able to really help that patient. So not only track the NCCN guidelines, but we're able to see when that patient needs intervention. I know one case I remember specifically was a woman who was undergoing treatment and was having some domestic violence issues as well. So we were able to document that and get her,
Get her in touch with the social worker.
Right, the social worker. And so it's a really great tool in order to track, so if there's maybe a pattern with, are there a lot of women that are experiencing this, we're able to go back and see that with different social situations.
Despite my enthusiasm for the Navigator program, it would be wrong, I think, for me to not stress the fact that the person with whom the patient will be most likely engaged is the nurse oncology manager, because they will be seeing that individual every time they come in for their chemotherapy. And that gives the oncology manager an opportunity to answer many, many, many questions while they're going through their infusions, right?
Right, and there's some care coordination models and things that just show if you kind of front load that, and really try to make sure that they know how to call and when to call, and that you can call them after their first chemotherapy session and see how it went, and call them the day before and say, are you ready, or any questions, just to build that trust so that they know if they do have a question that you're going to answer their call, or you'll return their call. Sometimes we'll even say, maybe we're not available, but call and leave it at 3 a.m, and then you can go back to sleep and not have that lingering. But just, some place that they can get an answer, not that we have all the answers, but that we would know who to track down. We say we can, like the physicians can kind of run, but they can't hide from us. We can track them down, and we do. We build up a lot of trust with them. Though I think it's nice to have this navigator in place too, that we could work collaboratively and just reinforce, and we have a level of trust that has to be built. They don't walk in trusting us, but I think the more time you can spend up front, and really know that you will answer me if I have some nausea or some side effects. You will call me back. You will re-explain this if I call and say, I know they told me this, but I don't understand. Those phone calls drastically reduce after a while because they become comfortable and trusting and know what to expect.
Well, and they start understanding what's going to take place. And, after they have that first chemo treatment, then going into the second one, they know they have something to look back on. So,
and they're valuable for me. They get to know exactly what's going to happen, and then that helps to add to my experience of I haven't been through it, but this is kind of generally what patients tell me.
Yeah.
So it's kind of hopefully a two-way street.
But I think despite our efforts at one-on-one care, it would be unlikely that that individual with access to a laptop would not, at the middle of the night, scurry out of a room, Dr. Britigan, to find more information. Would you have any recommendations as to how such an individual approach the plethora of unorganized information
Yes.
that is available on the web?
I do, and that would be to get a guide through that information, and that would be a medical librarian associated with a medical center, preferably, or a hospital librarian, and to express any questions that could be helped by a medical librarian, and to be open to the fact that there may be some framework to answer as far as the currency of the information and where is it from, and going through the little steps that we do to verify the source of the information and how it's being presented, and the fact that it's valid and reliable and evidence-based. We want to make sure that the information that the patients are getting is very trustworthy. As you said, we need to keep their trust. The other thing would be to, as you said, that amount of information is so overwhelming. And so to narrow down to address a certain topic at a time and go with bits and pieces of information as needed is better than reading about things that maybe don't pertain to that individual.
Unfortunately, there are many books on the subject, and they are often outdated by the time they go in print. And so I find them of little use. Certainly the treatment of the HER2 positive breast cancer patient has evolved rapidly since Dennis Lehman first described the HER2 site in the cell surface of the breast cancer cell several years ago. And so it would be unlikely that many of the things that we're speaking about today would be available in a recently printed book, which would be almost out of value within a matter of months. And a surgical oncologist, I can tell you that not a month goes by that something new does not affect our practice pattern in breast cancer, perhaps more so than any other cancer I am involved with, specifically solid tumors. And so I think books may or may not be useful, but as Dr. Britigan said, a librarian with access to contemporary sources may be far more useful in this setting. I think we all have patients who keep a journal, right? Mm-hmm. And yet the journal is useful only as a retrospective tool. It's not really a lot of help at the time that they have that question in the middle of the night. And so I think the access to the navigators, or the access to a family member who's been affected, or somebody who's been along with them, certainly may be far more accommodating than having to make a phone call in the middle of the night to the emergency room because they have concerns about nausea and vomiting, or because they're having trouble with a fever. However, the fact remains that these patients still need to be seen in the hospital, and we do appreciate the help that we can get from all the members of our community to avoid exactly that, right? The midnight visit to the emergency room was something that could have been addressed by our colleagues in medical oncology in advance of that. What do we think? Mm-hmm. You often see patients in whom you anticipate, right? These problems, and rather than let them go home, you say, look, this is your second dose. The first one didn't go so well. Maybe this one may be a little better, but not as good. But whatever happens, you give me a call, because we can still adjust, right, your treatment in a way that hopefully after 1 or 2 doses we can be in a situation where you'll be able to deal with this without having to show up in the emergency room in the middle of the night.
Right, and I think some anticipating and sort of getting to know your patients. You know, who might need that extra attention, you know, and I'm not sure I can exactly put my finger on how you know that, but you do.
Yeah.
Right, you know, who would like a call the day after their chemotherapy, you know, or even after their 3rd chemotherapy, you know, or the Friday before a holiday weekend or something, you know.
Right.
Some patients literally say, like, I don't want to think about you when I'm not here, and that's okay, but you just sort of get to know your patients and anticipate, you know, what their needs are. How much do you want to know from me? You know, do you prefer that I just tell you? Do you like it written? You know, is it something you want to hold? Do you like to go on to the, you know, our EMR portal and look things up, but just getting to know what works for them.
I think lastly, it would be remiss of us not to address what to do with the patient who, despite the fact that you've done your best effort, as happened to me just recently, who faced with this protracted almost 4 to 6 month trial by fire until they go through the OR, would suggest to you that they are likely to get another opinion, as happened again recently, when she had already purchased 2 round-trip tickets for what she called was alternative therapy. What I've tried to let the patients know is that if they do make that decision, that they should not ignore what we have offered as the best practice approach. Unfortunately, they may not get to your doorstep, so that you can help explain to them how the chemotherapy not only may be documented to be effective, but that they can actually see, which is the beauty of this approach, that the chemotherapy is working early on, so that despite their propensity to seek alternate care, if they were just to start with this approach, they may ultimately see that it's working.
I think there are some things that professionals can incorporate when they're talking with their patients, and creating that trust and shame-free environment where empowering patients to ask questions is very key, and opening that relationship that you can ask me anything you want to. I'm not going to scoff at that is very important. And the fact that asking questions of a provider is very difficult for a lot of people. Some don't raise their hand and ask questions in any setting, let alone in a hospital setting or a clinic setting. And so giving them that open-ended invitation of, instead of saying, do you have any questions for me, you could say, what questions do you have? And that's actually going, it sounds subtle, the difference sounds subtle, but it actually portrays the expectation that you might have questions. Instead of, yes or no, do you have questions? It's what questions do you have for me? And little things like that, looking at the big picture of timeline in those 3-week chunks, as Dr. Silva mentioned, so that you can give a big picture overview of what a patient can expect over the next few weeks and months is helpful. But breaking it down complex instructions into simple points, each step at a time, and making a plan, a realistic plan together for what's realistic for the person to do is important. And we only find things out like that by asking questions. Do you think you can do this? And if not, then let's find what you can do. And like you had said, and then using everyday language instead of the medical jargon that we're so ingrained and familiar with.
I think something very simple that I sort of created for myself, a dictionary of terms and all my chemos and drugs, because they give you the little pieces of paper, or you ask a question, what is this, drug I'm taking, and then you have to go look on the internet. But they just had something simple so that you know what kind of, that we had, what's the legal name of chemo before you have, a mastectomy. All those things like that, so you can know. So when you're throwing out terms or you're looking at your pathology report or something else, you can somewhat say, oh, okay, I understand that word. And that may lead you to ask him a question.
You have to keep reminding yourself that this patient has not gone to medical school and has not learned the vocabulary. And so even terms that we take for granted, we need to use everyday kitchen table talk, living room language when we're talking about different things to watch for. If you want them to be watching for any signs and symptoms of complications, then use words that describe that instead of arrhythmia, or redness. Just say, if there's anything changing and you have questions, let us know early rather than later, because you want to foster that sense that you can come to me with anything, big or small. And using those things and then asking the patient in their own words to share what you went over with that visit, because a non-confrontational way of doing that would be, now when you go home and your family says, what did the doctor say, what will you share with them? And that's a way of then for you to listen and just hear what they have understood. And if there are certain points that were key in your mind that you're not hearing from them, then you may need to revisit those and make sure that that gets included in the loop again for them to be able to share with their family, and keep those points as low as you can. 1 to 3 points of information at a time is digestible for most people, but if you get beyond that, maybe you need to schedule another visit and then go into that much detail again later. So those are some of the things that it doesn't bring that patient back, but at the same time we want to prevent someone from feeling that they need to go to the alternative measures, perhaps by building that relationship that you can communicate well with the person and they don't feel like intimidated to ask questions or that you're talking down to them, because people sense that in an exchange and a relationship, and there are ways to be very partnering in and informing so that that shared decision making can happen, and that it truly is a partnership going forward.
Well, and I think, as a patient, if they feel that you genuinely care about them, that makes a big difference in their care and then how they're going to handle everything that you tell them also. Because I know for me, when I was first diagnosed, I was with a different doctor, and it was just a matter of, okay, you have breast cancer, what do you want to do about it? I mean, he wanted an answer right then and there, and, my husband and I just kind of looked at him like, what? Can we go home and discuss it, So at that point we knew that surgeon wasn't right for us, and so we changed doctors. And the very first time I went to my new doctor, I mean, he took the time, he drew me pictures, he explained everything to me, talked about what was going to happen, talked about chemo, and possible radiation. And I looked at him and I was like, you care about me, don't you? And he's like, why wouldn't I? So I think that helps. If the patient can, feel that you truly care and that you don't consider them just another number, another surgery, that'll help them too.
Well, I think in the setting of HER2 positive breast cancer, there's no question that there are going to be multiple cooks making the soup. And I think the earlier you introduce all those individuals, the radiation oncologist, the medical oncologist, the surgeons or surgical oncologists, the genetic counselors, and the navigators, I think the patient will get that information from multiple sources. So, in a way, the HER2 positive breast cancer patient does provide us an opportunity to have multiple specialists and multiple healthcare givers as well as navigators to be on the same boat, the same plane, and that oftentimes will be all the assurance the patient needs to realize that what she heard from one wasn't something that would not be the best for her. So on that comment, I would like to thank you all for participating in this set of very instructive series on the management of the HER2 positive breast cancer patient.